Good morning. My name is Terry Lake. I'm the CEO of the BC Care Providers Association and EngAge BC. Before we begin, our President Ali Devji recognized the First Nations territories upon which the BC Care Providers Office resides. I'm coming to you today from Kamloops on the territory of the Tecumloops to Secwepemc. And I would be remiss if I did not recognize the remarkable and devastating revelation of 215 children's bodies found at the former residential school here in Kamloops. And I just want to let everyone know that we have heavy hearts here in Kamloops, across BC, and I'm sure across the whole country. So I'd like to just reflect on that for a second and know as a country we must come together and recognize and work hard for reconciliation with First Nations and the terrible history of colonialism in this country. But I'd like to welcome all of you here today. It's a really important session on day one of BC Care Providers EngAge BC Virtual Conference 2021. And I'm really happy today to have with us André Picard, who is an award-winning journalist, writes for the Globe and Mail, of course, as everyone knows. He's been here since writing since 1987. And André, I want to welcome you here and also thank our sponsor of this session, TELUS Business. Thank you to them for bringing this session to us today. André has written a groundbreaking book, Neglected No More. I'm sure many in our audience today have read this book. It's really a great uncovering of seniors care in Canada, and I think goes a long way to explaining how seniors care developed. And so we're going to get into a lot of what's in the book through our questions. But André has been recognized as a top public and policy critic in Canada for a very, very long time. He's a graduate of the University of Ottawa and Carleton University and received honorary doctorates from counting, to this point anyway, 6 universities. And the University of British Columbia recently announced André as one of the Asper visiting professors in the School of Journalism, Writing and Media for the 2020-2021 academic winter session. That's why he's coming to you from Vancouver today. In 2020, André was also awarded the Owen Adams Award of Honor, which is the highest Canadian Medical Association award available to a non-physician. Please join me in welcoming André Picard, who will provide some opening remarks. André, over to you and welcome.
Thank you for the warm welcome. Thank you for the kind introduction. You must have gotten the facts from my mom with all those details, so that's very nice of you. I just want to say a few opening remarks. I'm eager to have a conversation with you, Terry, but I'll just make a few opening comments because I was reflecting. I was just on a call-in show not too long ago, and the question they had was, how do you want to live out your final days? Where do you want to live out your final days? And it was a really interesting conversation, people calling in. I don't think this audience will be surprised to hear that the vast majority of callers said, given the current context, I never want to go into long-term care. Some people said, I'd rather die than go there. But many people recognize, if I'm lucky enough to live long enough, probably care like this will be necessary. So there's that really mixed message. But I think the underlying message for me that nobody wants to lose their autonomy, or at least they don't want to admit they will. And no one wants to be taken out of their community. So these are challenges, I think, for the sector and for society. I think there's also these kind of conversations are a reminder that this sector is never going to win a popularity contest. It's not Disney World. It's tough stuff that you have to deal with. But to me, what I retained from this and many other conversations about the book is there's always 3 words that come up again and again. That's autonomy and respect and dignity. That's essentially what everybody wants. They don't expect it to be magic. They don't expect life to be grand at all times, but they want to be respected and treated well. And I think that's the kind of care we have to aim to provide. And that's to me, the book I've written is not about COVID. COVID is the launching point, but it's about the sector. It's not a condemnation of the sector. I hope it's not read like that. But it's about these larger themes that I've written about for decades. How do we ensure every Canadian gets the right care, the right place at the right time? I think that's really our challenge across the continuum. How do we structure our health and welfare system so everybody can live to their full potential, regardless of who they are, their level of ability, where they live in the country? And, in all our health care interactions, how do we prioritize quality of life and not just quantity? People want to live well, they don't want to live forever. So I think those are the big challenges. I'll just say, every report, and there have been many, we can talk about this, but there have been many reports on how to fix the sector, how to fix Medicare overall, and they all say the same thing. They all essentially say it's a systemic issue. So that's the message of my book. Essentially, I say right up front in the book, well, if the problem's systemic, let's fix the damn system. That's what we should focus on. I don't think it's important to go looking for scapegoats to, have stopped passing the buck. We have to just stop talking about it, and we just have to start fixing it, roll up our sleeves and start doing stuff. So I guess I'll leave you with that message to start off with, and I look forward to the conversation.
Well, thanks, Andre. It's a great place to start. And let's start at the very first line of your book, which says, when elder care makes headlines in Canada, it's usually news of the worst kind. And it reminded me a lot of when I served as health minister and I was doing an interview with Bill Good, who is a radio talk show host in Vancouver. And we had an unfortunate hospital incident. And I was trying to explain that, so many good things happen in healthcare. And Bill, with his sonorous voice, said to me, "Minister, we don't cover the safe landings at YVR. We only cover the crashes," which reminded me that, when you do have headlines about a system, it's usually, the bad kind. But before COVID, Andre, how would you describe the quality of life generally for elders in Canada?
Yeah, I think, that your point is an important one, that in the media, one thing we do poorly is provide context. So we do cover just the bad stuff. I had my very first editor 40 years ago was someone very much like Bill Good, who would say, the sun rising is not news. I don't want to hear about the good stuff, right? Get out there and get the dirt for me. And I think that's the way we operate, for better or worse. So we have to try and give that context. And when you write something like a book, it allows you to get into some of that nuance a little more than in a story. But I think the quality of life for elders I think it's just not good enough, is the simple explanation, whether it's in institutions, whether it's in the community. I think there really is this systemic neglect of how we treat older people. I say in the book, that the generation that gave us Medicare has essentially been forsaken by it. Right? They made lots of sacrifices. Society's changed a lot since the Second World War, but we haven't kept up. We still have a system that's built from a time where we just assumed people wouldn't live very long. We have pension plans that were made for people for 65. And why is it 65? It's not a random number. It's because the average death was at 67. Pensions were designed to be a short term, here's the last couple of years of your life, a little bit of money to get by when you're hurting. And we just haven't adapted to the new reality of 100-year-olds and being the fastest growing demographic in society. So we have to really do fundamental shifts to adjust to the demographic reality.
And, you point out that COVID really exposed the vulnerability of seniors. And you said, we should have done more to raise the ramparts around seniors, particularly those in care. And, when we look back, it seems obvious, but why? If we go back a year ago or to March of 2020, why was it that we didn't build that iron ring or raise the ramparts around seniors' care in Canada?
I think it's the same explanation that explains a lot of problems in our health system. Is one, we're victims of our history. So in this case, we were really guided by SARS. SARS hit our hospitals hard. It, for some reason, didn't hit long-term care homes. It doesn't really make sense, but we just assumed it would be the same. It's another coronavirus, things will be the same. And add to that, we have a very, very hospital-centric system. Everything's about hospitals. And our hospitals have done exceptionally well during COVID. There have been very few outbreaks, very few deaths, other than people going in there and dying. They've done exceptionally well because they have all the resources. They did everything right. They did raise the ramparts, but everybody else suffered as a result. The system, once you get out of the hospital physician care, which is what's covered by Medicare, everything else is really second-class citizenship. And we saw that come to bear during COVID in a horrific way.
And even though the first elder to die in Canada, first COVID death was at Lynn Valley here in BC, the first wave in BC was actually handled quite well, and somewhat limited compared to Ontario and Quebec, where it was absolutely devastating. I mean, and I think people thought across the country that every province was sort of going through the same thing. But I mean, the situation in Ontario and Quebec was absolutely horrendous. How do you explain what happened in those two provinces versus what happened in British Columbia?
I'd say there are two or three main things. One is there's no question the pandemic started earlier in Quebec. Quebec had this weird, the March break is earlier. Quebec really was hit hard early. So there's just a lot more COVID in the community. Once it's in the community, that's the biggest factor, right? For homes, they're going to be at risk. So that explains of the large numbers there in part. Infrastructure is much older and worse in the east than in the west. The buildings there are just old. A lot of you don't see the 4-bedroom rooms in the West the way you do in Quebec and Ontario, where they're not quite the norm, but they're 30-40% of institutions are 4-bedrooms. And, I lived in Montreal. There's a lot of homes that are 100 years old, 120 years old. They're not built for modern infection control. So there's the infrastructure, there's the early seeding of the virus. And then finally, to BC's credit, they acted quickly. They did things, Bonnie Henry, banned the movement of workers between institutions really early on, which is something to this day hasn't been done in Ontario, actually. That we know that was the principal reason that it spread. And this is not to blame workers. They had to make a living. Again, it's a systemic issue. So those three things, I think, added up to much worse outcomes in the East. Now, the real tragedy to me is, why did BC have such a bad second wave? That was, we let down our guard. We were a little lax on the movement of staff, got more into the community, and you paid the price for that. So again, the explanations are the same in the second wave here as they were for the first wave in Ontario and Quebec.
I mean, our public health officials, I have tremendous respect for them, worked alongside them as minister for 4 years. And they are, among the best in the world, there's no question. And they understand epidemiology, they understand infectious disease inside and out. But I'm not sure they understand seniors' care. And I wonder, I've often wondered why we didn't combine our public health officials with experts in senior care, like our seniors advocate, for instance. Would that have been a more sort of innovative approach to help tailor the response to seniors' care in the face of a pandemic?
Yeah, I think you've hit the nail on the head for a broader problem all over the country is we didn't tailor our responses enough. We had very blunt instruments, shut down society or shut down a region, and we didn't adapt, things like locking caregivers out of senior homes. That didn't make sense, right? Anybody who knew anything about senior care knew that was suicide. And we paid the price for that. But you're right, that's what happens when you don't have people with specific knowledge about different parts of the sector. And the same can be said about schools. I don't think we had the instruments used in schools were a little bit too blunt as well. And again, you have to get that mix of expertise in public health, but I don't think they tapped into other specialties quite enough. And again, this is not unique to BC, certainly.
And obviously we saw that, the result of that was the separation of caregivers and family members from their loved ones in care. And when we think back on over a year that people were almost held in solitary confinement, can you talk about the impact that had on their physical and mental well-being?
Well, there's no question it was a massive impact, right? We know that COVID was deadly. We've had about 25,000 deaths in Canada, 17,000 of those in institutional care. So that's the brunt of deaths. But there are many other deaths from other things, from isolation, neglect, et cetera, and they're much harder to measure. I know this not only professionally from writing about it, but personally. I had a father-in-law living in a nursing home who died. He didn't die of COVID. He essentially, we say, he died of a broken heart. He died of loneliness. He was, before the pandemic, a very fit 88-year-old who played tennis 3 times a week, went to church every day, played bridge. After 6 months of being locked down, he was a person whose spirit was crushed. He sat down in his chair after lunch and had a heart attack and died. And we just, that the feeling there was that he had given up. And I think that's a very common thing. But how do you measure that? But I think that was so devastating. And I don't think it had to happen. I think we could have equipped family members. I think there may have been a few more COVID deaths. But I think the risk-benefit trade-off would have been much greater if we had treated people better and, again, with more respect. People recognize, again, that they weren't going to live forever. They wanted to spend time with their family, and they didn't mind taking the risk, and we should respect that.
Yeah, talking about your father, my dad is very much like that. He still lives independently, in Kelowna, with his wife, who's not much younger than him. But my dad's 89, and when I talk to him on the phone, he just doesn't really have much reason to get up in the morning, especially since the Canucks didn't make the playoffs. Like there's just nothing to look forward to. And I think, I somehow we didn't get the balance right. And I think that's one message that we have to learn. And this morning, talking about how do you allow that connection to continue in a safe way. This morning, I was reading in the New York Times about Labrador retrievers being trained to sniff out COVID. And, we've had other technologies, rapid tests, for instance, that we simply have failed to use as a way to protect people and allow visitation to continue. What are your thoughts about the testing regime generally across Canada compared to other countries that have had far greater use of testing?
Yeah, it's really puzzling. Our views about rapid testing are very puzzling in this country. We literally have millions of tests that are just sitting on shelves that have never been used. I think long-term care is one place we could have used rapid testing much better. We certainly could have used PPE more smartly for families, et cetera. So I think we had many tools at our disposal, and we just didn't do it. There was this, there's a real fear in healthcare, fear of taking risks, of innovating, that's never rewarded. So we just kind of boarded up these homes and said, well, we're protecting them. And I think there was a certain amount of paternalism there, even infantilization of seniors that, we're going to protect them, and that's we're going to tell them what they need rather than ask them what they want. And I think that's, again, reflected in our policies. Seniors in care don't have a lot of say, and this was the ultimate example, unfortunately.
You mentioned, PPE, and early on, I think across the country, we certainly experienced it here in BC, that long-term care homes, assisted living, simply weren't considered, in terms of the critical supplies of PPE. I mean, within a month or two, it started to flow. But, it seems like once we forgot about pandemics and moved on to other things, and, I remember worrying about the Ebola situation in 2014 when I was minister, and, we made sure we had supplies of N95 masks. And then everyone seemed to just forget about it. I know, as someone who worked in government, that you tend to deal with what's in front of you at the moment. Talk about government policy and how we prioritize these sorts of things. We never seem to learn the lessons.
Yeah, it's, we have, this better than I, but we have very reactive government, right? We have a lot of political micromanaging. To me, what distinguishes healthcare systems that are better than ours is they have an empowered bureaucracy. People don't like to hear this, but, having a really strong bureaucracy would have made for a better response. We see that in the countries that did best to COVID are people who can make independent decisions. They don't have to respond to the daily headlines of what went wrong yesterday. So the PPE one one is a really good example of we just neglected a group. It was all about hospitals early on, and people don't always recognize this, but between the vast majority of our deaths in Canada occurred between March 22nd and April 22nd. There was this real period of 1 month, really intense propagation of the virus, and it's because healthcare workers working in long-term care homes didn't have protection, right? And because they moved around. We created this perfect storm of virus propagation, and we're surprised that it happened. So it's, again, it was all predictable, sadly.
And, when we look at the different systems of care we have across the country, and, anyone that comes to Canada from other countries, Germany, the UK, they can't believe that we're sort of this mosaic of provinces that are almost like, well, it is a confederation rather than a federation in many ways. I mean, we're not one country, we're essentially 10 provinces and 3 territories. And the systems are so different. When I lived and worked in Ottawa for a few years, I couldn't believe that public health was largely a responsibility of the local government. And had been devolved down, and that the links in between the different sort of parts of the healthcare system, well, there were just so many. In BC, we have a regional health authority system, and there are some challenges associated with that. But it did seem to provide stronger links to sort of centralized directives and coordination. Can you talk a little bit about what you've seen across the country, the way healthcare is delivered, and what impact that might have had on seniors' care?
Yeah, so this kind of an obsession of mine is the structure. I always say that every problem in Canadian healthcare is structural or administrative. We don't really have medical problems, right? We have great medicine, we have fabulous healthcare workers across the continuum, but just the way things are structured, and as you mentioned, they're structured differently in every province, and it doesn't really make sense. I don't call it a confederation, I call it a confuseration, because it is very confusing, and I have to try and follow 14 jurisdictions, and it's almost impossible. But just to give a practical example, if you just compare BC and Ontario, BC, as you mentioned, is pretty centralized. They had really good messaging because there was a central messenger. There was Bonnie Henry. She was giving the message. Whether you agreed with it or not, that's irrelevant, but it was a clear message that was being delivered. In Ontario, there were really, there's 34 health units and there were 35 different messages some days. It was really a mess, and nothing is more important in public health than communication. That's the number one tool. They don't have any drugs, et cetera. They have vaccines, but for the most part, they have communication. And when you don't do that right, things fall apart. And that is the problem to this day. Ontario gets the vast majority of the media attention because it's the biggest mess. So the structure does matter.
Yeah, absolutely. But you mentioned the people, and we have great people working in healthcare in Canada, and I think when we look at long-term care, the amazing work that people in long-term care and seniors care generally have performed, it's under such trying conditions. And a big part of the problem, as I see it, particularly I think in Ontario, was this health human resource crisis that we've known about for many years. When half your staff are sick and half of the rest are afraid to come to work, you're left with, well, as we saw, 3 people looking after 115 residents, as you outlined in your book. We've known about the health human resource crisis for years, and yet the government really hasn't done enough to address it. How do you explain that?
Yeah, again, it's just, kind of systemic neglect, right? Nobody wants to deal with it. It's one of those things where you're never going to get any credit for it, right? You're only going to get a lot of grief. So I understand why politicians go, oh, health human resources, like who loves the HR department? No one. No one ever loves the HR department. So who wants to create a human resource strategy? There's all kinds of power dynamics there. Just a really practical example, why do we have many more pediatricians in Canada than geriatricians when we have an aging population? Well, it's explained by history, it's explained by the power of that profession. Pediatrics is more attractive, et cetera. So things like that just never get changed because they're so institutionalized. So we don't have a health human resource strategy. I think has to be a priority. I think it was a priority, should have been a priority before COVID, but it's certainly one afterwards. And especially that we're going to lose a lot of healthcare workers. This pandemic has taken a real toll on everyone from care aides to nurses to physicians. We know that there's already a shortage in Canada of roughly 10,000 nurses. Just for the positions that we have that are unfilled, it's about 10,000. People don't always recognize that. That's the number one reason we don't have surgeries going all the time. It's not because we don't have surgical suites, it's because we don't have nurses. Our surgery rooms close down at 3 o'clock in the afternoon because we can't have enough people for another shift. So these are real practical, this has an impact on all our daily lives. And again, we saw it in long-term care. We know prior to COVID that about 80% of shifts were not fully filled. And we don't know what the number was during COVID, but it certainly was more than 80. It was probably 100% of shifts were not filled, and some were dangerously unfilled. We have horror stories, as you mentioned, where staff abandoned the home. And again, I don't blame them for a second. We had situations, BC is not bad with its pay, but in places like Quebec, workers were getting as little as $13 an hour. And we're asking them to risk their lives, no PPE, work for 24 hours straight for 13 bucks. No, everyone would flee in that situation.
Yeah, and I know, going back when we were developing a health human resource strategy in the ministry, it was really hard to compete with other job creation initiatives, particularly the tech sector, right? I mean, that got all of the attention. The tech sector, the energy sector. And so when you went and said, yeah, we need, 1,000 more nurses and 2,000 more healthcare aides, it really wasn't sexy like it was to talk about, well, we're going to set up the next Uber or the next whatever. But I think if anything, this pandemic has shone a really, really bright light on the need to train more people here in Canada, and also I think as a pathway for new Canadians to come to Canada. Give me your thoughts about the role that new Canadians can play in the healthcare system and some of the barriers that they face.
I think that they play a really important role. We know that depending on where you are in Canada, there are different ethnic groups that dominate. But if you go to any hospital in Canada, the vast majority of people are going to be racialized workers. So in Quebec, it's going to be Haitian workers are the vast majority. In Manitoba, BC, Filipino workers largely dominate. And should we be encouraging this? Absolutely. A lot of people, I talked to a lot of especially care aides in the book, and that's really something, it's a path to citizenship, and it should be encouraged. We bring people over for nanny programs, and a lot of those nannies at night study to become care aides, because that's a way in. And then once you're in a care aide, you can be a registered practical nurse. And then if you're, if you really can save your money, et cetera, you can be and maybe a nurse practitioner. So these are ways of getting people into the system, and we can't operate without them. Now, that being said, I really worry about us pilfering developing countries, right? So that's really problematic. We steal a lot of workers from Algeria, from African countries. The Philippines is a bit different because they literally have nursing factories. They train people explicitly for export. So that's not as bad. That doesn't harm their system as much. But we have to be cautious of our role in the world as well. We shouldn't just be stealing other workers.
Yeah, I think that's a really important point. I'm glad you made it. We don't want to add to the inequity around the world, but I know that we hear from people who go to the Philippines to job fairs, and Canada simply isn't there like other countries are. And as you say, they're training nurses essentially for export, and these are folks that would love to come to Canada, and we know that they do play a very important role currently. So hopefully we'll see more of that happen. I played my wife and I played our first game of pickleball yesterday, and I on our family chat I told the kids, and of course they're all making fun of me playing old people tennis, and what do regular people play pickleball? Just and I said the only ism still acceptable today is ageism. And I know it's so prevalent because when I was younger, and still, I think I still am a bit ageist. I think it's almost natural because we're kind of afraid of getting to that point. But it's very real. And so I want you to talk a little bit about how that impacts seniors' care, and how, what can we do to combat ageism?
Yeah, I think it's a really important problem and a dramatic one. We use terms like the gray tsunami, for example, or the silver tsunami, which of course I personally take offense to, given my silverness. But what does that line tell you? It's sort of amusing, but it tells you that we catastrophize aging, right?
Right.
And we shouldn't. This is a miracle. This is the our life expectancy after the Second World War was 67. Now it's 82 in Canada. That's the greatest increase in life expectancy in the history of the world in a very short period. The I mentioned earlier, the fastest growing demographic, 100-year-olds, centenarians, most of whom are healthy. More than 50% of people over 100 live in the community. They're active. I always talk about, I have an uncle who's 91 who tours with a Dixieland band, and he complains because he says, I don't have enough time for sailing and tennis. This is the reality, right?
You mean pickleball, not tennis?
Oh no, he's hardcore. He's hardcore. So, but this is the reality. We forget this, that the vast majority of seniors are healthy. They have little aches and pains and stuff, but that's the price you pay for living a long time. And we have a very small percentage of people who actually live in institutions, about 7% of seniors. Very important group. They need to be treated well, but they shouldn't obscure the fact that the vast majority of people are doing great. And we can all wish for that, I hope. And then the final thing I'll say, and you mentioned it, is I think a lot of it is we bring on to ourselves. We don't want to admit that we'll get older and a little rickety, and that we'll play pickleball instead of tennis. And there should be no shame in this. We should be celebrating this, and we should, I think, even be adapting society to that reality. We should be building cities that are more accessible, that people can get around. We know one of the main reasons people get into institutional care is just banal things like they have trouble navigating stairs or getting to the grocery store or public transit. All of this is fixable. And if we have a society dominated by aging people, why don't we build a society for them instead of one that's really harsh and difficult to navigate?
Yeah, it's a really good point. And yet part of me, and I had this discussion with my deputy minister at the time, part of me recognizes that, when you look at the costs of healthcare, the vast majority of the cost to the system occurs in the last part of your life. And, when you think about all the money that we spend for that last 10 years of people's lives, if you were to take that money and invest in children, could you prevent or inoculate society from some of the the problems that we have? And there are people that argue that we overinvest in older parts of our society and underinvest in younger parts. So how do we strike that balance, in terms of equity? I always struggled with it, because I know that it's just a fact that you need more attention when you're older, obviously, in terms of your health. But that takes money away from investing in daycares and kindergarten and school. So how do we balance those two?
Well, I don't believe we overspend on elders. I think we overspend on sickness care. So I think we don't do enough to keep people healthy until they need care. The fact that we spend the majority of our health dollars, our sickness dollars on seniors, that doesn't trouble me a whit. That's exactly how it should be. That's how insurance works. We pay into it for 50 years and then we cash in at the end. That's, to me, how it works. And I think, again, we kind of blame old people for being old. And that's not how it should work. I think maybe we should pay more taxes in recognition of the fact that we're going to live longer and need more help. But I don't think that, saying that we should spend less on seniors is the answer. I think the answer is quite the opposite. Now, can we do that and also invest in younger people? I think so. I think we can do both. We saw in the recent federal budget $30 billion for a childcare program. I think that's a tremendous initiative. But as I wrote a column on this, I think that's tremendous, but I think we forgot the other end of the spectrum. I would love to see $30 billion on elder care. Because why? Well, the justification for spending on childcare is we want women to be in the economy. A lot of women care for young children. This is going to advance their careers. They're going to pay more taxes. It's going to pay off. But you can make the exact same argument for elder care. There are actually more women who care for older people than care for children. They suffer even more because they're more advanced in their careers. They lose their pension years. So often they leave their jobs altogether. So if you're already 54 and you have to care for your 84-year-old mom, why not leave a little early? We lose a lot of quality people because we don't support caregivers. So I think there has to be consistency in the thinking in these policies. And again, I think a little bit of ageism comes in there.
Well, I'm glad you mentioned that. We were talking recently about the important role of caregivers. I think my next door neighbor, he's in his 80s and his wife still, she has dementia, and but she's able to live at home because he has two adult daughters who come by and help him. He has some agency care as well. He's still in good shape, but he's saving the system, and his family is saving the system a tremendous amount of money because he's able to care for his wife still. What kind of policies should we develop to support family caregivers more so that they can stay at home longer?
I think first we have to recognize how big a contribution caregivers make. So we know from Stats Canada, there's about 7.8 million caregivers in Canada. That's a good chunk of people are caring for someone else. I've been there, or if you haven't been there, everyone's going to have their turn. Caring for someone and being cared for. So this is important. Now, that's 7.8 million. There's 780,000 of those people who contribute more than 50 hours a week. So these are essentially full-time unpaid jobs, and they do save a tremendous amount of money to the system. But I get to talk to lots of caregivers. I have that privilege. Almost everyone does this willingly and lovingly. But the problem, I think, is we exploit them. We literally burn them out. A lot of people, you'll know in this audience, get admitted into care homes in a time of crisis because their spouse has collapsed or whatever. They just can't do it anymore and they're stuck in hospital. So we have to give that support. And I think it's just a lot of little things. A lot of countries invest much better than we do in respite care. Just a break. We're going to give you 2 weeks off to recharge your batteries, and we're going to take care of your loved one in a nice long-term care home. And we're going to give you that break, and maybe this will give you a taste of where, how they can be cared for later on. You won't feel quite as guilty. So there's all kinds of benefits of doing respite care, tax breaks, to make sure people don't lose their pensions because they have to take time off work to care for their mom. And we have to, and I have to say it explicitly, I think everyone knows this, but vast majority of caregivers are women caring for women. That's the reality. And we have to recognize that too, that I think that's another reason we think exploitation is okay, because we not only have ageism in our policies, but we have a lot of sexism. We just assume that women should do this. They take care of the kids, they should take care of the grandparents, and we have to adapt to the reality of modern society. So I think there's no magic solution for the caregivers. There's all kinds of little programs. An EI-like program, an employment insurance program to take time off work to care for your loved ones. We need that. We have it on paper, but we don't have it in reality because it has this stupid clause where you're only eligible for this program if your loved one is going to die within 6 months. Well, first of all, who wants to fill in paperwork saying that? And secondly, how do you know that? People don't magically have an expiry date. Some do die suddenly, some last for a long time. We know that chronic illness is like this. It's not a smooth path. It's up and down. So we have to have policies that reflect reality, not policies that are fantastical.
Your book does a great job of explaining how we got here in terms of particularly long-term care. Spend a little time talking about the evolution of seniors care in Canada, because it started based on the prison system, which was a kind of an eye-opener for me and quite shocking. So spend a little time talking about that, if you would.
Yeah, it's funny. It's one of the questions I get the most about the book. I guess I knew this history. I took it for granted, but it did come up through the penal system, right? So it goes back to the Elizabethan Poor Laws of 1601, where it was the first time in society that we decided, what do we do with poor people, with the indigent? How do we treat them? And the philosophy then was, well, they have to work for their keep, right? We just can't let them be layabouts and be leeches on society. So we made them work for their care. So this is what happened to seniors who weren't cared for their families. And, you know, we have these fantasies in the good old days, everybody cared for their loved ones. It's not true. A lot of people were not cared for, they were abandoned, etc. And they ended up in these poor houses. And poor houses came to be so crowded that they started dividing them up, poor houses for older people, etc., elder homes, etc. So that system was brought into Canada with the British immigration. So that's what we had. And I think what shocks people the most is when I say in the book that this existed in Canada until the 1960s. Up until 1961 in Ontario, people in some care homes, not all, they wore uniforms like prisoners. They could be punished if they didn't do their chores. They'd be denied their meals. There was an inspector back then that was appointed who actually led to the law being changed. He was quite activist, who went around documenting, you know, seniors being locked in the basement, solitary confinement because they didn't do their chores. They didn't go to the field and pick potatoes. This is in my lifetime. And I know I'm not young, but this is the reality. And things have changed a lot, but we still have the vestiges of that. And the vestiges, again, I think they're more in the east part of Canada, which is older. But, you know, the homes literally look like prisons there. And that's how they were designed. They were designed as prisons, wardrooms, 4 to a room. There's a lot of those in the East. It's funny, in the legislation in 1961, the commissioner had to really fight because at the time wardrooms were 20 to a room. So he said he really wanted to have 2 to a room, but that was so unrealistic that government would never do it. So he talked them into 4 to a room. So there's all this history, and Canada, of course, is, I think, more than any other country I've ever visited, a prisoner of its healthcare history. We don't really change. Things get into, you know, structures get into place and we don't really adapt them and modernize them. So I think that history is fascinating, but it's also a bit frightening for people. And I should mention, it's not all penal system. There's a whole part, and I think this is more the West Coast version. A lot of religious institutions did this. But again, a lot of them were not, you know, they're Christian, but not necessarily charitable in the sense of it today. You know, it was the very basics, and, you know, you had to pray for your meals rather than till the fields, but there was very modest offerings that people got. And again, I think that kind of Presbyterian lowercase p way of thinking still exists in a lot of Canadian healthcare. You know, we don't decorate the walls, everything's very, very modest. And again, that's from our history.
Yeah, and I think that people have the impression that long-term care is still a bit like that. You know, you hear a lot of people sort of denigrating long-term care, and yet, you know, I've toured many long-term care homes in British Columbia, and it's certainly not like that. But what I do see is a lot of people with cognitive decline that are not engaging with each other or with the staff. You know, I mean, about 60% or more of people in long-term care have a fair degree of cognitive decline. How do we you know, how do we deal with that in a way that is, you know, that we can feel proud of as Canadians, knowing the difficulty, just the medical difficulty of dealing with someone that may not want to cooperate, doesn't understand instruction, particularly during COVID. This became very apparent in some of the behavioral units. Is there I'm not looking for a magic bullet here, but talk a little bit about the challenge of dealing with people with different forms of dementia in long-term care.
Yeah, first I'll start by agreeing with you. I think, you know, I get to visit lots of long-term care homes when I travel around. And I think, yeah, the most of them are decent, right? They're not exceptional. There's a few exceptional ones, but most is okay. And they do a lot with the resources they have. They're in a very tough spot. So I think I have to recognize, I try in the book to not be, as I said, it's not a condemnation in any way. But there's a few bad apples out there we have to get rid of. But I think for the most part, we just have to give them more support. I think with the dementia piece of the puzzle, I think a lot of it has to do is we haven't adapted, right? We haven't adapted to this reality. We just have this assumption people are going to just be a little old and rickety. And that's not what the case anymore. So we have to, I think, build start building homes purposefully. We have to actually build places built for people with dementia. So what does that mean? It means much wider corridors. Not, I learned an expression doing the book, corridor is what people call all these really narrow hallways in a lot of care homes. We need those wide hallways. We need walking tracks. I visited a couple of places with these lovely figure-8 tracks. I remember that from my dad having dementia. He liked to wander, but when he came up against a wall, it was very off-putting and it would make him very stressed. So you walk in these figure-8s. We need access to the outdoors. That's really good homes for people with dementia. You have access to the outdoors to walk. So this is about policies being purposeful for the needs of people. And again, we're slow to do that. We have some great homes that do this, but they should do it more widely. So I think a big part of that solution is infrastructure. The other part, and we haven't talked about this, but we all know the number one issue in all care, and especially in long-term care, is staffing. So you have to recognize that people with greater needs need better ratios. So we have terrible ratios of providers to residents, and they have to be even higher for people with dementia. So we have to recognize it's going to cost more money. And again, that's the reality of people living longer is we're going to have to invest more. And that, again, I don't see that as a negative. I just see it as a reality. And I know that, other countries do this much better, and they don't do it at tremendous, Denmark isn't going bankrupt because it has great elder care. Quite the contrary, they actually spend less on healthcare than us. So there's all kinds of arguments to be made for doing this better economically, ethically, morally, etc.
Yeah, and I think all of that is so important about designing, the future in terms of the infrastructure. And I remember when I was in veterinary school back in the 80s in Saskatoon, we started a pet visitation program. And I'll never forget a woman probably in her late 80s or early 90s who had dementia, and she was uncommunicative. And we took our white cat named Biscuit and put this cat on her lap. And she started petting this cat and had a conversation as if she was talking to her cat back on the farm. And the nurses and care aides were just amazed. That's the first time they'd heard her talk for years. That connection with a pet, or we see it with music. So there are these other things that we can add in that they don't fit into a medicalized system very well. And I think that impairs our ability when you talk about quality. And one thing I'm worried about with the pandemic and the aftermath is that we're going to over medicalize seniors care and forget about the quality. And we actually saw this in one of our health authorities taking out Christmas decorations because they thought they were fomites to increase the transmission of COVID. Can you talk about the over medicalization that may come after this pandemic?
Yeah, I think that's a real problem. I think it's a problem now, and it does risk getting worse. I often use we have to put the home in home care, right? Or in long-term care. So your home is not just your family home that you've lived in for 50 years. It's your nursing home room. That has to be a home. It can't just be nursing homes can't be hospitals without hospital care, which is what too often they've become in Canada. So we have to work and we have to get that balance right. We have to value what people value. Having their pets really matters. People fight tooth and nail to not get the 24/7 care they need because they don't want to leave their cat or their dog. So why aren't they allowed their homes? One of my favorite stories in the book is I talk about Sunnybrook Veteran Center, which to me is one of the most exceptional care homes in Canada. And there's a story in there where a person, and everyone there has dementia, the average age is 96. And there's a story of a nurse taking a resident out for a walk. They have a lovely garden there for people to wander in. And the residents started pulling up all the flowers, throwing them, hither and to. And the gardener came up, and the gardener was very upset and said to the nurse, "You have to stop him. I've worked all morning on this flower bed." She said, "It's his garden. He can do what he wants. This is his home." And to me, that's the ultimate philosophy we need is let's treat people like they're in their homes, let them live like they want. And again, I recognize this is hard to do when you have inadequate funding. When you're funded for tasks, you're not going to give people things that are not tasks, right? So we reap what we sow. and we don't fund things properly. Even if we fund, even if they were funded inadequately, which they're not, but even if they were, I'm not sure they're funded appropriately.
Yeah, that brings up a really good point about regulation. And again, I worry that the pandemic will result in more regulations that are a box checking exercise rather than outcome based. How do we get the right outcomes without the burdensome box checking regulations that that we live with today?
I remember visiting a home. This was prior to COVID, of course, but they showed me they had 91 pages of regulations of things they had to do, literally check boxes, but not one of them was about, are the residents happy? Is the
Yeah.
quality good, right? It's like, what temperature is the butter? All kinds of things that I care less about. And that's what we've done. We've made this a checklist. When I visit other countries, which is something I love doing, to visit their health systems, if you go to somewhere like Norway, which is fabulous long-term, they don't have a big book of regulations. They don't say, well, what are the regulations? Well, the nurses, the care workers know what to do. Why do we have to tell them? They fund them properly. You give people a decent salary. You give them power. You give them agency. And you say, take care of people the way you would take care of your grandmother. And the care is exceptional. And essentially, I'm not a big believer in trying to legislate good behavior. I think there's other ways of doing it. You give people the means to do it, and they'll do it. So I think we're, as you mentioned, I think we're going very much in the wrong direction in that one. Have to you get the numbers of people in there, you get well-trained people. We disempower our staff members so much. One of the things that struck me when I was researching the book is I talked to so many workers, and they didn't complain about their salaries or their hours or stuff. They just kept saying, I just wish I had more time to spend talking to people, just having a cup of tea. That stuff is so important to people's well-being, and we just don't allow it anymore because they have to do these 4 things in the next 15 minutes. I can't even mention the person's name. I don't have time because I don't want to engage in conversation, and that's not good care. It's maybe it's good widget making, but it's not good care.
Well, we'll make sure that all the policymakers get a copy of your book and commit to not over-regulating for no purpose. I mean, everyone knows that common sense regulations are needed, but I know it's so easy in government just to create more regulations as a shield, right? To protect yourself against the next criticism, next catastrophe that comes along. You spend a lot of time in your book talking about how complicated it is to find out the right pathway when you're looking at care needs. Through EngAge BC, we have a service called Route 65, which allows people to go on and find out in their area, what kind of services there are for home care, for assisted living, for long-term care, independent living, that sort of thing. So we're trying to make it easier for people. Because every time I have this conversation with my wife about the system, she just throws her hands up and says, I don't understand it. And then there's sometimes when I don't understand it. How do we make the system easier to navigate for people?
Well, the navigation is so essential, right? So I think we have to prioritize it. We have to say navigation matters. We know that if you have good navigation, you actually save healthcare costs because there's way less waste. You don't miss appointments. You get in the right place sooner, et cetera. So I think we have to invest in that. Again, I think we have to get rid of stupid regulations. I remember this was in Alberta. I was talking to someone, and you can call. They have a centralized line where you can call if you need a care home, but they're not allowed to talk about private homes because it's a government run. Well, people aren't stupid. So just tell them what their choices. Tell them what it costs. Don't pretend that something magically doesn't exist. So I think we just have to have more sensible stuff like that. So I don't know how you do that magically, but I think that's an overall problem in our healthcare system. We just don't know what's available. And to me, that's key. We have this fantasy in Canada that Medicare covers everything. And I think that's a big problem in long-term care. People just have this assumption, I get old, I'll be taken care of. And a lot of people are in for a big, big shock. And as you know, a lot of these decisions get made in a time of crisis. And that's why, and navigation becomes all the more important. So, really underappreciated people in our healthcare system are social workers. So there's a lot of social workers who do this, but they're overwhelmed. You have to know who to call and when, and people, it makes the system inequitable. You know, people like me and you who know how to wind through the system, we can get care for our loved ones. Not easily, but a lot easier than most other people. And it shouldn't be like that. It should be a level playing field.
And you kind of brought up in that response, private care. And, the return on private care, I'm not talking about independent living, I'm talking about long-term care. The return is relatively modest. I think generally agreed through the work of the seniors advocate here that this may be 5 to 6% return, which is compared to other investment strategies very quite limited. And yet private care gets vilified a lot. Talk about the role of private corporations in seniors care.
Yes, I get a lot of grief about this because there's a real movement to let's ban privatization, et cetera, especially in Ontario where there's a lot of private cares. It's the majority. It's again, very different in every province. But I don't think getting rid of private operators is a panacea by any stretch of the imagination. We just have to look at what happened in COVID. Quebec has virtually no private care, and it had the worst outcome. So ownership is not a magic solution. I'm not saying it's irrelevant. To me, what's important is I think care should be delivered by nonprofits. I think we have to break up the care part and the real estate part. So to me, the problematic people in long-term care in Canada is there's essentially some real estate developers in there. I call them slum landlords in the book. Maybe that's unkind, but essentially they're there to make money off the property, and they don't really care about the people. And I'm fine with them making money off buildings, but leave the care to somebody else. So the recent report of the Long-Term Care Commission in Ontario, I think, really did a good job of explaining this, how you have to divide those two functions. The real estate operators should not be delivering care. There's no question. So we have to figure that division of labor right. That we have return on investment, that doesn't bother me terribly. We have all kinds of private care in Canada. But the thing that always bothers me about private care is we have to just be much more clear on what's covered, what isn't, why, and people can make decisions, and we fudge that. We don't like to admit that, well, it's covered, but it's not quite covered. Like long-term care, when's it covered? Well, if you're poor enough. Well, how poor do you have to be? Well, how much money do you have? You never get a straight answer. Like, give people straight answers, tell them what's available, and people will make hopefully rational decisions.
Yeah, I mean, it is complex. Even I would argue in British Columbia, where we have a fairly well-designed system in terms of your income and how much you have to contribute of your income. But it's still tough to navigate, and we certainly don't consider assets as a test for your ability to pay. And I think we're fortunate to have an office of the seniors advocate here. Do you think that will become more common across the country after COVID?
Well, in the book, I have nothing but praise for Isabel McKenzie. I say that I think she's the person who's probably made more difference in elder care in recent years than anyone in the country. So I would really like to see that role copied everywhere. I think every province should have a seniors advocate. I also think in our political system, seniors ministers have to be actual ministers. They can't be these junior, you do the crap that the health minister doesn't want to do minister, right? Like in Ontario, again, you have the Ministry of Health and Long-Term Care, and the Long-Term Care Minister is off far in a corner, almost never heard from. It has to be at the front line. It's a big demographic, it's a big issue, and it has to be taken seriously and given some political weight.
I'll going to end our conversation there because I totally agree with you. And in the last election, we encouraged each party to form a seniors ministry that was dedicated to all the issues that we've talked about today. So I really want to thank you, André, and I want to encourage everyone watching today to pick up André's book. It's only $20. It's a heck of a deal. And I found it, well, it's an easy read, as André is such a great writer. Really does explain the system we have in Canada and some of the challenges that we have. So I encourage you to pick that up. So Andre, thanks to you for spending time with us today. Thanks to our sponsor, TELUS Business. And before we conclude today's session, I want to remind you all that we'll be having the Safety Care or Safe Care BC Safety Den, which if you haven't seen at previous conferences, has always been one of the key highlights. And after various workshops, take an opportunity to meet our exhibitors. You know, we wouldn't have this conference without our generous sponsors and exhibitors. And, you know, we're all getting used to this virtual world. You can go in and click on your a booth and interact with each of the exhibitors, and they are just essential. So I hope you'll take the time to visit some of our exhibitors today. We've got a great panel later today, what went right, what went wrong, and we'll look more specifically about COVID. On that panel, we've got some great people. Deborah Hauptman from Langley Lodge did a tremendous job through very tough circumstances. Joanne Tate from Vancouver Coastal, and Dr. Bob Bell, who was Deputy Minister of Health in Ontario. So we worked together in the past, and he's done a lot of work in this area. So Andre, thank you once again, and we look forward to the rest of the conference. Thanks, everybody.